So actually, this is just this talk is for actually physicians and practitioners who are actually dealing the patients as a first contact. And I thought that we will have this an overview of on CKD. And as Dr. Amit Gupta has suggested that in the future talks, whenever we have discuss a topic, we must have the main focus on nutrition, because our society's main purpose is of actually improvement of nutrition. So this is, I will be discussing about the management of CKD, what are the available options. I will be mainly concentrating on the management part. So diagnosis is very important, because once the patient has been diagnosed, in fact, the diagnosis is much delayed in CKD, because actually the symptoms occur only when almost 90% of the kidneys are damaged. So sometimes patients are coming to us already in CKD stage 5. So it is very important that we must have the early diagnosis, and that's why the early screening and early evaluation of CKD is very important for management of CKD. Just to highlight, the simple test is the urine test is the most important test. It is, if a good urine examination is almost equal to a kidney biopsy. So simple urine test, dipstick method for urine albumin can be done anywhere. And these days, the auto analyzers are available even in smaller places also. So we can have good laboratory setups even in tier 3 cities also, not to talk of metro cities. So there is no problem. But unfortunately, that renal screening is not done in majority of the patients. Even those patients where there are causes like diseases which can cause kidney disease, like diabetes and hypertension, two most common diseases. Still, these patients for years together don't have a proper urine examination as well as a kidney function test for years when they are being managed by physicians. So I think it is very important that physicians have to be educated that urine examination is very important, and the recommendation is that once in a year, every type 2 diabetic and once in 5 years type 1 diabetes should have a urine examination as well as renal function tests. 24-hour urine can be done for quantitative protein excretion. And EGFR, now we taught in terms of EGFR, and most of the laboratories, in fact, along with serum creatinine, are giving the values of EGFR. So it is very important that physician should be well versed with CKD staging of CKD stage 1 to stage 5, depending upon GFR. And not detailed, but simple urea and creatinine and sodium and potassium are very important for diagnosing CKD in these patients. And because anemia is a common feature, so blood cell counts and hemoglobin estimation should be done on follow-up visits. And abdominal ultrasound at least once in follow-up should be done just to know. Sometimes patient may be having congenital absent one kidney, and that is only diagnosed on ultrasound. Patient may be having polycystic kidney disease. Patient may be having asymmetric kidneys. So these are very important, that even when we see patients coming to us, diabetic patients, hypertensive patients, so they have not been evaluated as far as ultrasound is concerned. And biopsy, wherever indicated, should be done. One should not hesitate today doing biopsy, because biopsy will give us a histological diagnosis where indicated. And if need be, then CT scan can be done. If ultrasound is not giving us required information, then MRI, where then a DTPS scan again is a very important for evaluating the function. Now, what is our management actually? Once the patients are coming to us with CKD, so what are our goal of management? So one is that whatever kidney function is there, we cannot improve, at least to preserve the renal function as far as possible, because even the 10% of kidney function also is sufficient to avoid renal replacement therapy, and that is better than maintenance dialysis or kidney transplantation. So our effort should be to preserve renal functions as much as possible, delay the need for dialysis as well as transplantation as long as possible feasible, to alleviate extrarenal manifestations, because the most of the patients who are coming to us, CKD patients, will have anemia, easy fatigability, and weakness, loss of weight, loss of appetite, nausea, vomiting, bony pains. So these, let's see how we can alleviate these extrarenal manifestations and to improve the blood chemistry values. So blood chemistry includes actually mainly calcium, phosphorus, apart from urea, creatinine, sodium, potassium, calcium, phosphorus, serum proteins. So it is very important that the malnutrition should be avoided in these patients, because almost 2/3 of patients, once they reach CKD stage 5, will have significant malnutrition. And dialysis patients invariably are malnourished in our country. So because the reason being that for years together, they have been on protein restricted diet. And our protein restricted diet is not actually 40-gram protein diet, which we routinely write in our prescription. Because a patient who is already vegetarian, in fact, if you calculate actually his protein intake, it may be as low as 20 gram of protein. So these are the patients where you may have to give some protein supplements to maintain adequate protein intake. So that similarly, the quality of life of these patients will depend upon whether they how is their nourishment. Because if they are well nourished, then they will have less incidence, chances of infections, less chances of complications of advanced CKD. Then another thing is that all these patients are more prone to get complications, like suppose infections, pneumonias, diarrheas, urinary tract infections. So whenever these complications occur, it is very important that if need be, then patients should be exacerbated, because these are the causes of acute on chronic renal failure or acute on chronic kidney disease. So if you see that patient, like all shun, like hypertension, congestion, infection, obstruction, so the dehydration. So all these are the causes of acute on chronic kidney disease. And we must identify the acute factor because it is very important, very rewarding if you can identify the acute factor and correct that factor. And in that, I will add is the toxins also, right? NSAIDs, painkillers, and in our country, Ayurvedic medicines, which is overuse or chronic use of Ayurvedic medicines, various bhasams and heavy metals, again, is a very important cause of acute on chronic kidney disease. Then another entity which has been identified is CKD-U, especially in southern parts. So that is whether related to some pesticides or quality of water. Again, that is very important. Now, almost 16% of patients of CKD are due to CKD-U or unknown etiology. And protein restriction, very important that in fact we should give, do not restrict too much of protein intake, and give adequate protein intake, and that too of good biological value, high biological value. And sodium, potassium, phosphorus intake has to be, again, there is a role of nutritionist here. I know that in India, as Dr. Amit Gupta mentioned, that we do not have a good nutritionist support. I can't in fact count even 10 centers in India where we have a good nutritionist support in the department of nephrology. So only few departments like SGPJ, Lucknow, or with Georgie at Chennai, they are having proper nutritionist support. So most of the centers, and that holds true for private setups. In private hospitals, we don't have a dedicated renal nutritionist. So that part, I think one has to be, it is a team effort, team approach, and coordinated effort of physician, nephrologists, and nutritionists and family members. So it is very important that we have to involve the family members also in the management of nutrition in these patients. And water intake should be output plus 600 ml or 500 ml. That is our standard rule. But depending upon the situation, whether and the temperature, whether we have to decide how much fluid intake is allowed in the patient. Weight record is very important. At least over a period of once admitted patient, we should do daily weight record. And otherwise, at least once in a month or once in 3 months, patient should have a weight record, because most of the patients come to us with weight loss. Then smoking cessation is very important. Smoking as well as alcohol should be avoided, because smoking now has direct relationship with progression of CKD and hypertension, cardiovascular disease. I think we have to ask patients to stop smoking. Then herbal medicines again should be avoided, and painkillers, as I have already highlighted. Now, treatment of the cause like diabetes, hypertension, these two are now the most common causes in our practice. And diabetes is the number one cause, almost to the tune of about 30 to 32% patients are due to diabetes. Then other autoimmune diseases, again, and primary glomerular disease is the main cause of chronic glomerulonephritis. If patient has fluid overload, obviously then diuretics and furosemide and torsemide can be used. And in patient is in gross congestive heart failure, even IV injections have to be given. Our goal of hypertension should be blood pressure of 130/80. And in that too, it is more important, actually holds true for diabetic patients, because in diabetic patients, we have to be strictly blood pressure under 130/80. And best agents, antihypertensives, are ACE inhibitors and ARBs. Then anemia management has now changed over the past 2 decades, with the now frequent availability of erythropoietin, darbepoetin, as well as intravenous iron, which has been now a routine treatment in patients of CKD, because it has been found now that patients usually do not tolerate oral iron well, so have to be given intravenous iron. So now we have much safer preparations of intravenous iron available, like carboxy maltose, and even iron sucrose. So these are routinely used in our patients, even pre-dialysis patients as well as dialysis patients. So iron estimation and serum iron, more important is actually T-sat, T saturation, transfer saturation, and ferritin level. These two are very important. If T saturation is less than 30% and ferritin is less than 500 nanogram per ml, so this is the indication of giving intravenous iron in these patients. And ferrous sulfate and ferrous ascorbate are the two preparations commonly used in our practice. But only thing is that this sometimes causes gastric upset, as well as there is a decreased absorption in uremic patients, and plus it can change the gut microbiota. So that's why oral iron actually is to be avoided in patients who are on CKD stage 3+. Then hyperkalemia and metabolic acidosis, one must look for in these patients, because hyperkalemia can be a life-threatening complication, and it should be managed with calcium gluconate, soda bicarb, and insulin, and then definitive treatment with chelating agents and dialysis. Hyperphosphatemia, again, it is the role of nutritionists for seeing how much dietary phosphorus patient is taking. And the phosphate binders is a part and parcel of the treatment of prescription of nephrologists. And physician also, they must look for phosphate level in these patients and manage, keep the phosphate as far as possible within the normal range, but should definitely be less than 5 mg/%. And various phosphate binders available are calcium carbonate, calcium acetate. Now we have ferric citrate also available, and which is now more and more is being used now. Then calcium again has to be monitored. Vitamin D supplementation has to be given, and 125 dihydroxycholecalciferol, which is not synthesized in CKD patients, has to be supplemented from outside. Then pruritus again is a very, very disturbing symptom in these patients, and various creams are available in the market, like capsantrim, apart from simple drugs being used for treatment of pruritus. So newer treatments, we have Dr. Sunil Prakash here, who has done a lot of work on keto analogs in CKD and showed good response. So only problem is that it adds on to the pill burden, and because you have to give almost 6 tablets daily. Then now soda bicarb therapy, again given in thrice a day So again, these are all pill. This all is adding to pill burden in these patients. If whatever I have taught so far, every slide is adding some tablets to the patient, whether it is phosphorus management, whether it is iron management, whether it is calcium management. So there is a pill burden almost to average and antihypertensives. All patients are receiving at least minimum 2 to 3 antihypertensives. None of the patient is on single antihypertensive. So all these are adding to pill burden. Then we have now SGLT2 inhibitors. Over the last 2 years, it has been now recommended as a use for, started with diabetes and CKD, but now even for CKD also now the recommendation has come that you can safely use it up to a GFR of 30 ml per minute. And it has shown beneficial effect in patients of CKD. Then nutrition. Here comes the role of nutritionists. 35 kilocalories per kg body weight less than 60 years and 30 to 35 in more than 60 years. And for again, if patient is feeling weakness, then individualize the patient, look for how much oil he is taking, then whether any extra salt he is taking, and then supplementation if patient is not able to take, especially in vegetarian patients. And that's it's in stage 1 to 3, 0.75 gram per kg body weight protein, 4 to 5, 0.6 gram, and stage 5, 1 to 2. On dialysis patient, we have to give, in fact, normal protein intake, that is 1.2 gram per kg body weight. In a peritoneal dialysis, see patients on PD, in fact, one has to be very careful that he takes this much protein intake, because almost 6 gram of protein loss can be there in 24 hours through peritoneal dialysis. So malnourishment is very common in dialysis population and advanced CKD population. Similarly, fluids, you have to look for how much fluid intake can be allowed, depending, and you estimated dry weight has to be evaluated in every patient. Then coming to renal replacement therapy, the main two therapies are available. One is dialysis, that is hemodialysis and peritoneal dialysis, and renal transplantation is the treatment of choice. In fact, that is the transplant only which will bring the kidney functions to normal, that is GFR to near normal. Dialysis is only a palliative treatment, and it can never replace a successful kidney transplantation. So this is dialysis where we remove the waste products by there is a extracorporeal circulation through which through a machine, and the artificial kidney, that is a dialyzer, and it can be used on both emergency basis as well as maintenance basis. That is the dialysis machine. That is just to show for the physicians who actually are not exposed to dialysis units. And we have principle of dialysis as diffusion, osmosis, ultrafiltration, and then we have even online hemodiafiltration also in newer machines. So dialysis can be twice a week dialysis or thrice a week dialysis, or even now there is a concept of nocturnal hemodialysis or home hemodialysis now is picking up even in India as well. And the main criteria that if the patient is not feeling well, it is not only that you have to see the urea and creatinine and GFR only. Otherwise, a GFR patient's GFR less than 15 ml per minute will require dialysis support. But if patient has uremic symptoms, unresponsive hyperkalemia, and volume overload, acidosis, bleeding diathesis, then the patients will definitely require dialysis. The various vascular access available are, one is catheters, that is internal jugular catheter or permutates. Best vascular assets and the most successful and which will last for a long time is the arteriovenous fistula, and the most common site is radiocephalic fistula just at the wrist, or it can be brachiocephalic fistula. So fistula is actually the lifeline of a dialysis patient. Fistula is where you join the artery as well as vein, and a good fistula is vital for successful outcome of maintenance hemodialysis, and good survival will be only possible if patient has good vascular access. Otherwise, even patients on perm cath or AV drafts or IJ catheters, we usually will have many complications on follow-up, but fistula gives the best rate of survival on maintenance dialysis. Then anticoagulation we routinely use heparin on every dialysis because that is very important. Otherwise, blood will clot. And if the patient is not, there is some contraindication, then we can use in emergencies a saline wash and heparin-free dialysis can be done. Various complications actually we see during dialysis. I think a physician should know that patient can get hypotension, muscle cramps, dialysis disequilibrium syndrome, dialysis first use syndrome, especially with the dialyzer. Patient can have first use in dialysis reaction, arrhythmia senator, cardiac arrest senator. So we have to stress to the family as well as patient as well as physician also that it is a lethal procedure. It is a potentially fatal procedure. Patient can die during dialysis. It is not that dialysis is absolutely safe. In spite of the machines which now are quite safe, we don't have blood leads or air leads or air embolism these days. But still, patient can have cardiac arrhythmias and death during dialysis. So intradilated hypotension can occur, hypoglycemia can occur, hemorrhage can occur, toxic water system treatment, contaminants due to water, patient can have complications like hemodialysis, then encephalodialysis and this encephalopathy can occur, and various infectious complications which are more commonly seen with catheters as compared to fistulas. Then certain chronic complications like chronic blood loss, anemia, cardiovascular disease, vascular calcification, calciphylaxis, nephrogenic systemic fibrosis, nutritional complications, and infections are seen in dialysis patients. And peritoneal dialysis, where we use the peritoneal membrane of the patient's own abdomen as the membrane through which fluid and dissolved substances are exchanged with blood. And it is used to remove the kidneys in these patients. In fact, peritoneal dialysis started in India in 1989, and since then, regularly there has been a steep growth as far as PD was concerned. But over the last 5 years, the peritoneal dialysis use has gone down. The reason being that there are more and more hemodialysis centers. Almost every day, new hemodialysis center is opening in our country, and somehow our patients they are much comfortable with hospital setup treatment rather than home treatment. So they feel comfortable that when they are being supervised by a technician as well as doctor, and the twice a week therapy somehow they prefer rather than being the continuous daily therapy at home. But we have to advise this procedure to the patient. Unfortunately, more than 50% of the patients are not aware of this modality of treatment as renal replacement therapy. And in one of the study published by Dr. Mahajan from AIMS, it was almost more than 50% patients, they had no idea about peritoneal dialysis as a renal replacement therapy. That this is a advantage we have to tell to the patient. That patient has greater flexibility, he can travel, and he has even cardiac patient will have better tolerability. So all these factors have to be mentioned to the patient. Hemoglobin management will be better in these patients because it is a totally bloodless procedure as compared to hemodialysis. This is how the catheter is placed in the abdominal cavity, and that this catheter remains throughout the life if there is no complication, and patient can continue with same catheter for years together, this peritoneal dialysis. And that is how there is a bad inlet, and then there is a drainage pad, and usually 3 exchanges are performed every day, and same process can be done with a machine also, that is called automated peritoneal dialysis. So you can have that machine used in the night, and in the daytime patient can be totally free and he can do his routine activities. The various complications, most important complication actually is peritonitis, and second is malnutrition. So these two are the main complications. But with now better understanding whether nephrology, and if proper education is given to the patient, we can reduce the incidence of peritonitis. Other complications can be there like hypotension, fluid retention, And we can have low back pain, hernia senator, because all the time fluid is stained in the peritoneal cavity, and hyperlipidemia senator on long-term use. Transplantation is the treatment of choice in renal these patients. Most of the time we put this kidney in the right iliac fossa, and it is very important to know for the physicians as well as for the patients also, that most of the time the old damaged kidneys are not removed, and the new kidney is not put in the in the original renal fossa. It is put in the right iliac fossa or left iliac fossa, and we join it with the arteries which are going to the lower limbs, and the ureter is joined with the native bladder. The kidney can be diseased donor transplantation, or it can be live donor. And live donor can be in our country we have a human organ transplant at according to that we can have only from the related donors, and as exceptional cases we can have distant relations also donating, but that has to be approved by the committee which is appointed by government authorities. So use of most of the time patient stays in the hospital for about 7 to 10 days, and after that patient is discharged. And every patient has to be put on immunosuppressant drugs to prevent rejection. The common immunosuppressives used are tacrolimus, mycophenolate, and prednisolone. And earlier we were using cyclosporine and azathioprine, but now majority of the patients are on tacrolimus and mycophenolate. Then patient on follow-up can have complications like rejection, recurrence, and then we have to do draft biopsy, and then we have to modify the treatment accordingly. So ultrasound as well as DTPS scan is very important for evaluation of a kidney transplant patient. Coming to diet, again, the transplant patients usually are advised to take the fresh meals only and avoid usually cut fruits. So all sorts of infections, and again water, preferably boiled water, and to avoid eating outside in the eating joints, street food should be avoided, so that they should avoid infection, because these patients are all immune suppressed patients. The commonest complication, the most important complication is rejection followed by infection, and then other complications like they can have hypertension, accelerated hypertension, recurrence of the disease, and on long-term follow-up, they can have lymphomas, especially, or other solid organ malignancies as a complication because of prolonged use of immunosuppressive agents. Again, the nursing management is very important in these patients. So nutritionist management as well as nursing management is important in these patients. Now, various artificial kidneys are being developed actually. So one is artificial, wearable artificial kidney. Then we have even implantable kidneys. So these are now advancements going on, especially in US, but still not available in the market. So not put to clinical use, but I am sure in future something is going to be available.
End-stage renal disease.
This is just to, I will show you one here.
Thousands of people die each year.
So this is a machine, small machine,
super efficient,
which is being developed in California, San Francisco, and one of our Indian Dr. Subir Roy is involved in this, where nanotechnology is being used, and with this they are having biological membranes. So this will be a implantable kidney which will be doing continuous hemodialysis in our body. So let's see, that is how it is placed in the right iliac fossa, like a transplanted kidney.
Toxins to the bladder as waste. The artificial kidney will allow patients to live untethered from dialysis machines, eat and drink more normally, and live their lives more freely. Completion of this ambitious project will profoundly improve the quality and length of life for patients with kidney failure, as well as reduce the cost and personal toll of this devastating disease.
Because if you see, there are only, this is Shubho Roy, actually. This is an Indian who is working on this. So actually there are only...
End-stage renal disease afflicts 1.5 to 2 million
is about the size of the top part of.
This is another peritoneal dialysis based wearable kidney.
I can dance.
This is a wearable kidney, but it depends. It is based on peritoneal dialysis. That is how again a wearable dialysis kidney where the fluid is again regenerated in the in this small machine only, and same fluid is being used again and again. This is a wearable artificial kidney using peritoneal dialysis. So the research is going on both the fronts, peritoneal dialysis also and hemodialysis also. So let's see which one comes first and wearable. But still it is a long way to go. We don't know whether it will be available in next 1 or 2 years or so, but and at least this will definitely met. There is a huge unmet need. If you see that there are only 9,000 transplants being done in India, and only 2 lakh hemodialysis done in India, and about 7,000 patients on peritoneal dialysis, and rest all patients are not getting any treatment. Almost more than 2 lakh new patients are added every year. So if there is a huge population which is not being given effective renal replacement therapy in our country, this is not only India a problem of India, but it is a global burden of CKD, and CKD is really now almost like a pandemic, and one has to work at all levels, and best will be to stress on prevention of CKD, and that's where there is a role of physician. That is that you have to control diabetes effectively, control blood pressure effectively, and screening and early evaluation of chronic kidney disease, so that patients do not reach the stage end stage renal disease. Thank you so much.